Hey ResusXers, Salim Rezaie here, and for this talk I want to tell you guys about a new randomized clinical trial. It's actually the first ever comparing delayed sequence intubation to rapid sequence intubation. I'm surprised this hasn't gotten more traction on social media and people talking about it, but I think it's worth talking about because before, DSI was all expert opinion with maybe one observational trial to support it. Well, now we actually have a randomized clinical trial that tells us once and for all, when we apply this to a general population of trauma patients, does it actually work? So here's the title page of the article: Peri-intubation hypoxia after delayed versus rapid sequence intubation in critically injured patients on arrival to trauma triage, a randomized controlled trial. Now, this is an RCT of 200 agitated trauma patients needing intubation. I've left the PMID number there for you at the bottom of the screen, and you can just use this when you go to PubMed to search for this paper and pull it yourself. Now, anytime I review a paper, I always advocate for people reading the paper themselves because it's always good to get other people's perspective. And those of us that do this all the time, having other people kind of check us and double check us. So the clinical question these authors were trying to answer is, does DSI decrease peri-intubation hypoxemia in agitated trauma patients requiring definitive airway control compared to RSI? So the first thing we need to talk about is, what do the authors mean between DSI versus RSI? So delayed sequence intubation was IV ketamine 1.5 milligrams per kilogram, but it was given in 0.5 milligram per kilogram increments until the patient was appropriately sedated and not as agitated trying to pull things off. The patient then got pre-oxygenated for 3 minutes. They then got a dose of IV succinylcholine at 1.5 milligrams per kilogram and then subsequently intubated. Rapid sequence intubation is exactly what you would think. Patient was pre-oxygenated for 3 minutes. They got IV ketamine at 1.5 milligrams per kilogram, not in the aliquots that was done in DSI. Rapid succession, they got IV succinylcholine 1.5 milligrams per kilogram, and then the patient was intubated. So that's what the authors mean between DSI versus RSI. Now, both groups had a lot of things in common that I think are worth mentioning. So first of all, what do we mean by pre-oxygenation? In these patients, it was face mask at 10 liters per minute. All intubations were performed by second-year anesthesiology residents. And then the laryngoscope of choice was direct laryngoscopy, which is interesting because we just had a big trial called the device trial that published saying that for trainees, it seems that video laryngoscopy is better than direct laryngoscopy, but we get what we get with these studies. Now, the patient population, the most common reason for intubation was altered mental status. As a matter of fact, the median GCS in both groups was 6. The most common cause of trauma in this study was blunt trauma from motor vehicle accidents, and 82% of the patients, so 4 out of the 5, were blunt trauma. Now, their primary outcome was peri-intubation hypoxemia. The way they defined that was an SpO2 of less than 93% from pre-oxygenation until 1 minute after intubation. When you look at the numbers, DSI was way better than RSI, 8% versus 35%. Now, their key secondary outcome was first attempt success. So how was this defined? So an attempt was defined as insertion of the laryngoscope beyond the teeth. Success was if the endotracheal tube went through the cords. So when we look at the secondary outcome, and although the study's not powered for this, DSI did better than RSI, 83% versus 69%. Now, I have a couple of commentaries about this study. So the first thing I'm going to tell you is that they were monitoring SpO2 pretty methodically at every minute. And when we look at the SpO2 values, the only time RSI was better than DSI was at baseline. And we're talking like 91% versus 92%, which I think we can all agree is pretty equal at baseline. But then at every minute increment after that, DSI was superior. It was superior to RSI. It wasn't even close. The second thing I want to mention here, and this wasn't explicitly stated in the paper, but I think is worth mentioning, is that there were 17 patients that were not intubated on first attempt in DSI. Of those, 8 of them were due to oxygen desaturation. That was 47% of the reason why they couldn't intubate on first attempt success. In RSI, there were 35 patients not intubated on first attempt success. 31 of those were due to desaturation. That was 89%. That is more than double the number of people in DSI. Now, this is hypothesis generating, but to me, what this tells me is that DSI in agitated trauma patients does a better job pre-oxygenating our patients and avoiding that peri-intubation hypoxemia. Now, there are some confounders here. So first of all, no knock on second-year anesthesiology residents, but if we had somebody that was maybe more experienced, would they have gotten the intubations faster in the RSI group, and maybe we wouldn't have seen as big a separation between the groups? It's interesting that they use direct laryngoscopy. I can understand why. Trauma, maybe bloody airway, anatomically difficult. A video wouldn't be as helpful in those scenarios. But as I stated before, we know that in trainees, video laryngoscopy is going to be the optimal laryngoscope to use for intubation, not direct laryngoscopy. And then I don't know what the experience of these intubators was with bougie, but we know that people who are facile and feel comfortable using bougie as their first attempt intubation, maybe that would have made a difference in this study. I don't have any of that granular detail, unfortunately, in this publication. What I'm going to tell you is that we now don't have just expert opinion. We don't have one observational trial. We now have a randomized clinical trial that confirms that in agitated patients, DSI does better than RSI. And my clinical bottom line from this study is that in agitated patients not tolerating pre-oxygenation who need definitive airway control, DSI is going to reduce the incidence of peri-intubation hypoxemia compared to rapid sequence intubation and should be the go-to strategy. Well, Haney, thank you for the invitation. I hope this sparks some conversation and some debate. I don't know how often people are using DSI. It is certainly something that I use pretty frequently in my practice, depending on the patient that presents in front of me. But I think now we have an evidence base that helps support that practice.